is there, what's happening. So it's a win.
New Zealand's most distinguished professor of public health says coping with emergency and repeated failures of the border, you could face another lockdown.
Sir David Skett told News Hub 6 border incursions in 3 months is serious. Investigations reported like a lot of this story.
You guys are my guinea pigs for the first time, so hey. Right, those guys on Zoom, can you hear me now? Yeah, I thought you could. I'm just testing you. Anyway, so as I said, certificates will be sent in due course, probably not this week. You are being recorded, so hopefully you're happy with that. Share it with your, once you get it, you can share it with your colleagues. Any questions for those on Zoom, just send it to me via chat. And I'm going to hand over to Wendy, and it's her night, and she'll introduce her topic and all the speakers.
Kia ora everybody. Just making sure, can everyone hear at the back? Okay. So thank you very much for coming. This evening is very exciting. We're going to launch the Mobility Action Program, but also to provide some context. So it's giving an idea of all the different available pain services that there are in Northland, and the idea then is that it's providing a good idea of the referral pathways. So as you can see, it's quite a tight agenda, so that's why we've decided to do the questions at the end. Where was it? Okay, so the Northland Mobility Action Program is a program which has been designed to help people that have got chronic longer than 3 months functional pain that is non-ACC. So basically it's an evidence-based, cost-effective, patient-focused program where we ran a pilot program back in 2016 to 18, and we found that there was evidence of reduced pain, improved function, and also it was cost effective, and that was run throughout New Zealand in 17 different centres, and that was funded through the Ministry of Health. In addition, it prioritises services to Māori and other population groups that experience inequalities to health services. So there's a dual purpose. One is to improve the access to service, but also to, in the long term, prevent joint replacement surgery. So it's also person-centred. So we're developing packages of care that are individualised to patient need. So these packages of care are multidisciplinary, including physiotherapy, pharmacy, occupational therapy, podiatry and nutritional advice, depending on need. There's also the capacity to expand that. So at the moment, that's what we're looking at in terms of the packages. We're also looking at group-based options, both within the pool and the gym, and we're working really closely with Green Prescription. In addition, we're going to be running some group education sessions, so ideally quarterly, and that will be an opportunity for people to come that are part of the MAPS program, where they can come as a group, and the MDT will support with mindfulness, self-management, problem-solving strategies, pain education, nutritional advice, depending on the needs of the group. I'll also be looking at developing a lot of resources, so virtual resources through the web, social media, exercise videos. So we're in the process of developing some exercise videos with Sport Northland, and that way you'll be able to have it either on a DVD, a USB, or click onto YouTube, and that's safe exercise. Objective measures and quality assessment framework will be built into the program, so that we've got good objective measures that we can prove the outcomes to our funders. So just talking about the two different levels, we've got level tahi and rua. The tahi is more designed for people with mild symptoms, and this is more physiotherapy based and gym based or hydrotherapy with the capacity to also do group training. So it's 5 sessions over 8 to 10 weeks, and then also linking with the green prescription. So we're looking at the physio drawing up an exercise program so that they can work together with the trainer, and we're getting a bit more value out of that. And then the RUA package is more comprehensive, so that's where we're looking at more moderate symptoms, and we've got that capacity to individualise to suit the patient's needs. So this is a maximum of 7 sessions over 3 months, and again can include physio, OT, pharmacy, nutritional review, podiatry depending on the need, and then linking with green prescription once again. So in this package we're looking at having a lead clinical provider. So typically in this case either OT or physio, but I'm looking at OT where they're performing an initial hour assessment. So they're coming in and helping to develop what additional services are required, and also looking at the self-management, problem solving and patient education. Also the option of having a clinical pharmacist to do the reviews of the medications and providing recommendations back to the GP. And then we're indicated also linking in with our mental health providers as well. So at both levels, as discussed, we will have a group-based focus, so having both educational, group-based and also small group work. So where there is no service, so for example, where I've been going around more in the far north, there's that ability to develop service as well. So for our funding, there will be 2 separate streams of funding. The main stream will be through the Ministry of Health funding, but also through MSD. So MSD has committed to funding patients that have got community services cards, and also that would be eligible for the disability allowance. The idea then is that that's going to really increase our spread. Mahi Tahi Hawara will provide the also full funding for Māori, and then for part funding for non-Māori there will be a $15 surcharge, so that will increase the capacity to spread our funding. So in this way the project will be more sustainable, bridge the equity gap, and will have a greater reach, so we're not running out of our packages of care so quickly. So the key referral criteria is that they must have longer than 3 months of functional impairment and be excluded from ACC. So for example, we're looking at mild to moderate OA, impingement syndrome, bursitis and tendinopathy. There will be no restriction on specific joints as there was in the initial pilot. We've tried to have our fees competitive because it's one thing from the pilot, that was the feedback. So we're looking at a $70 per session for our providers, so that it's competitive with ACC. So the rollout, we're from November, the next 2 months, I'm looking at doing a rollout in locality 3. So locality 3 is basically all of these practices. So it's a small controlled rollout so that we're able to test any issues that might come up. We can also have the main computer system ready, so that's going to be ready in January, and we're going to be doing just a basic health link referral for the next 2 months just to step it through. And then in 2021 we'll be looking at the whole of Northland and using the main system. So it's just showing the referral process. You're just going into MedTech and you're clicking on the health link icon and then typing in Mahi Tahi Hōora and going into compose the referral. And then we'll need quite a, because it's free text, reasonable amount of detail of what service you're wanting, so that it's easy for me to triage. But I'll come round and I've developed a guide and I can help to provide some input with that. From 2021, it will be through the main PCRMS system, which is through Enigma. And again, this will be MSD as well. So we'll be checking if they're eligible for MSD, the funding, the pathway will be through there, and if not, the funding will come from Mahi Tahi Hōora. Similar to mental health, there will be a certain number of packages that will be assigned to practices depending on the population. The key thing with the funding as well, with MSD, the funding will be paid directly to the patient because that's their policy. But the funding from Mahi Tahi Hōora will be paid directly to the provider. So these are the key objective measures. The short-term measures, we're looking at pain, function and quality of life, and that will be taken at the beginning and at the end of the program. And then our long-term measures are looking at repeat GP visits, whether the patient's presenting to orthopaedics, ED visits, so it might be spinal, whether they're requiring any ongoing imaging, and then whether they're receiving ongoing MSD assistance. So it's linking in with our key funders and key aims. They will also have a complete a consumer experience survey so that then we can learn from that as well. So training, I'll be looking at coming around and doing a bit of a roadshow. So we've developed some guides and it'll be just getting a time that's convenient for practices, referrers to come round and go through the process. But there will be ongoing support throughout the life of the project. And I've just got my contacts here because from now on, anyone that would like to come on either as a provider or to arrange time to come around the practices, we can do that. So yeah, thank you very much for listening. Next slide will be available. Okay, thank you everybody. So our next speaker is Stacey Townsend, and she's from ACC, and she's going to provide an overview of the pain programs. Thank you.
Thank you for having me. I'm just going to keep this quite short because I think the evening's actually more about outside of ACC, but what I'm going to do is just go over some brief information about our 3 different levels of services that our ACC clients can access, who the providers are, because we've had that request come through, just wanting to know which providers in Northland there are. And to be honest, that's probably about it. I could do questions, but we'll do those at the end, I think. So just go forward from there. So we have 3 levels of pain services at ACC. One of them at the moment, mostly around New Zealand, we haven't been able to get set up, and that's the group education sessions. However, I am going to be talking to one of the pharmacists in our area to see whether or not we can kind of change that this evening. The kind of second level is community services. So there's 2 levels within that, and that is early intervention, getting in quick when there's pain flags and things like that that you've identified with regard to their injury and how patients are managing their pain and your life around that. Those services are all delivered locally. So when I say locally, anywhere in Northland, so it should be in the client's own community, in their own home, and fit around what they do and what they're sort of trying to get back to and things like that. There is some travel required for parts of that. So community services is multidisciplinary, so it has the various different providers that you might need in there: OT, physio, psychologist, medical reviews, really lots of different aspects to that. However, as you can imagine, some of our medical providers don't necessarily live in the client's area, so clients do have to travel sometimes to see those people. Although we do now have telehealth for quite a lot of that, which is a really good development, and that's, I think, just been announced that that's sort of a permanent change that we're happy with now at ACC, which is great. And then we have the tertiary services, so that's where they have the residential kind of inpatient type services over sort of 10, 15 days, I think it is. And that in our region is only at the Auckland Regional Pain Service at Auckland Hospital. So those are the 3 levels of service that we have. So in Northland, we have 6 different providers, although one of them is Auckland DHB, just providing that the higher level of service. So clients would generally start at the lower level rather than kind of jumping straight to that residential service, needing to sort of have a go in the community and try and get some traction that way. Obviously, pain management services needs to be related to the accident, so whatever the covered injuries are, that's what's got to be causing the ongoing pain that they're suffering from. So we've got active, APM, TBI health, habit and proactive are our 5 ones in the local community here. And they all have providers up north and things like that travelling around there. So in terms of referrals, so a little bit different to what you might do for public health ones. They literally just come straight to ACC. So we have a little bit of a pathway there. As a practitioner, so GPs, physios can make those referrals by first of all finding out, has the client got a case owner already? Best place to ask that question obviously initially is ask the client if they've got one. And you can go from there, but if you're not sure, then the provider helpline can point you in the right direction to get to the right person to get a referral underway. So you can either do that by phone or by email. They have their own They have their own phone line providers. So generally speaking, it's a really quick wait time on their call, and they can quickly have a look into a claim and just see who's managing that to point you in the right direction. So I don't really want to kind of take up any more of your time, because I think tonight's more about what we're going to be doing for non-ACC clients. But happy to, at the end, take questions and things that might relate to any ACC queries that you have and that sort of thing. And I can also, if anyone does want that, kind of go through some of the changes that we've sort of had at ACC recently. But again, I'll leave that till the end if anyone has those questions. Thank you.
Thanks, everybody. So we've got Dr. Chantala Joda from the pain service at the DHB, and then Dana's going to speak, who's the pain psychologist as well. Thank you.
Kia ora, everyone. It's a big team that we have here today, and we're very excited. Initially, when the pilot program for MAPS was run over the 2 years, we were so excited to see the outcomes. We were privy to the outcome measures that were provided, and it was great to see. And we were waiting with bated breath whether they're going to roll this out, whether there was going to be funding for it. So it's very exciting. So I'm one of the team members that we have at Whangarei Hospital. You'll meet Dana after my bit of the talk. We named ourselves the Northland Area Pain Service. We've been and relocated at the hospital. So just an overview of what I'll be talking about, just to get to know our team, our current model of care, and what we would like, we're proposing. And then just the broader concepts of pain. And I think maybe I'm in the middle with the talk, but given what Wendy's talked about here, it just kind of gives you the concepts in pain and why we provide an sort of overall service, not just about the pain itself, but the person. So it kind of gives you an idea as the background as to why we're thinking that way. And then acute versus chronic pain and the differences between the two, and therefore why we treat them in a different manner as well, which is different to our traditional biomedical thinking. We, as clinicians, we're trained very biomedically, and so we've had to learn and evolve with time because we're dealing with the whole person most of the time. Yep. So our team, it's myself and Anthony, the doctors on the service. We're both employed by the Department of Anesthesia and both work in anesthesia and pain. So we're not there full time. And our team, our service is pretty much held together by our nurses, Jen and Jess, who are our senior nurses, who field the calls from distressed patients and from GPs, finding out why patients are waiting very long. We've also, over the years, been supported by Alka. Lots of you may know her. She's the psychologist contracted to our service. And then just recently welcomed Dana to our team, who will be staying on next year once she's fully qualified, and she's been doing a great job. We've also been supported, and traditionally we've sort of not having dedicated FTE to our pain service and been fighting for that vigorously. But over the years, really well supported by our team physiotherapists at the hospital and occupational therapist one. So basically borrowing FTEs from the other services to help us out and people with interest in pain. And also supported by the psychiatric team, the psych liaison team in hospital, both for inpatient care as well as the outpatient service. So our current model of care, we provide an acute pain service. So we involved in the pain rounds in the hospital and all the wards actually. So over the years, it's also evolved into a very complex service, just the acute pain round, because our patient demographic and also the patient nature of their complex issues, their comorbidities have really challenged us. And then we also provide the chronic pain service, and we have various types of clinics at the moment, either just the doctor, nurse, or more complex with the psychologist or psychiatrist, and there's nurse-led clinics. Procedural clinics are a very small part of what we do, and also follow-ups. And the wait list currently is up to 24 months. That's why we're also very excited about when the program. So our triage process for the proposed model of care is dependent very much on our quality of our referrals. We would like for the investigative pathway in most cases to be complete, and we will triage patients to either a one-on-one meeting for an assessment that we do currently. We afford our patients 90 minutes for the comprehensive pain assessment, because by the time they get to us, they've got a very long story. Their journey has been very complicated, and we've got to give them that time. And hence the long wait list, because if you can't get through much if you're doing a 90-minute assessment. And for those who can be in a group setting, we will start with an understanding pain lecture, which will be in about an hour, delivered by the doctor, supported by the other team members. The treatment part of our process starts with the education, and for patients to understand why we have a model of care and where we're coming from and how the whole person is important. So when they leave, our expected outcomes are there will be a subset of patients who will be armed with knowledge, feel reassured that they're on the right track, go out there in the community, work with their GPs to get improved quality of life. There will be a subset of patients who will not be ready to interact with our team or accepting of the current thinking of pain concepts. So those patients will be discharged because they're unlikely to engage, but it will be open to them to come back when they feel they're ready. And then the next group of patients would maybe opt for a little bit more intensive work with us, and we would invite them back for an assessment and treatment planning day, which will be run over one day. Very minimal input from the doctors. We talk to them about the biomedical aspects of pain and medication, rationalizing medication use, understanding medication harm, in particular opioids, benzodiazepines, all the sleeping tablets, so all of that type of thing, and what harm can be done from just treating with medication. The rest of the day is run by the physiotherapist, psychologist, and hopefully an OT involved as well, going through the physical, social, and psychological aspects to understand themselves. They'll have a workbook, come away with knowledge and maybe a little sort of guideline as to what to do with next steps in the community. There will be some patients who will need a little bit more input, and we will screen them for a group treatment program, which will run over a few weeks. We don't know yet how many weeks. We aim to pilot all of this hopefully next year when we do get more resources, and put our program together. Our sources of information are from our college, the Faculty of Pain Medicine. The International Association for the Study of Pain is open to everybody for membership. That's where we get a lot of our information, all the studies published in the journal. We've shared a lot of our current material from the team in Australia, Newcastle, the Hunter Services, and we aim to give our service our identity, a New Zealand identity for the people, our sort of wide cultural aspects, and also Northland as well. So we have the ability to, or the opportunity to be unique. We will audit ourselves via an electronic process where we can measure ourselves against ourselves, but also against other pain teams in the country and outside in Australia and Asia. So to know that we are being effective and our outcomes that we're looking towards are being achieved. So moving on to a little bit of, I took out all my slides that were neurobiology totally, so I'll not make this a lecture about pain, but just to understand how we've come through this journey of understanding pain. For 20 years, they've had a definition of pain being an unpleasant sensory and emotional experience described in those terms. So as of this year, they've redefined this after having great consultation. So it's not only seeing as an unpleasant sensory and emotional experience, that already tells you a story about what pain is, but they added 6 keynotes to that. This was done in consultation with the pain specialists, experts in the group, the ISP council members, and also in consultation with patients with pain and their people looking after them and supporting them. So they came up with 6 broad concepts. I'll just skip to that. And so if you look at the 6 concepts, and that will give you tie-in with what Wendy is providing, what ACC is providing, is that pain is always personal, and the biopsychosocial aspects of patients' lived experience is very important. You've got to take that in consideration. Pain and nociception, for those who are wondering about nociception, it's just the sensation, the messages that go to the brain to say there's a potential harm or there's actual harm happening, and the experience of pain is 100% produced in the brain. So it doesn't mean that you have a message from the periphery going to the brain that you will always get pain. It's what is processed in the brain to produce a pain experience. So we need to understand, we have a saying, hurt is not always equal to harm. So you're in pain, yes, but you may not be in harm's way. And I'll expand on that later. So the life experiences of patients, you've got to take that into consideration. That's what molds them into experiencing their pain. And we always have to respect what the patient says. It's their experience. It's not what we expect after providing a treatment or advice. It's what the patient tells you is their pain. Pain is usually served as an adaptive role to protect us, but sometimes it can work in the patients, causing them more harm. So in their understanding of pain. So we've got to take that, how it affects them psychologically and help them through the process. And if somebody is not able to verbalize their pain, that does not negate their experience of pain. So we have to also take that into consideration. So those were the 6 main things. And if you look at the hand on that side, we've borrowed that from our colleagues in Newcastle, and we will develop that further. We added sleep in the center. They usually use the 5 fingers, but those are the aspects. If any of you had to read through our long pain reports from the 90-minute consultation, you will, especially in the past few years, you will see those different areas or aspects in which we talk to patients about. So basically, pain is an adaptation. The body uses pain as a message to keep you safe, to tell you, to warn you about harm. And so it helps you retreat from whatever is causing that danger so that you can heal, and the immune system does the job if there's an injury or inflammation. patients can vary in their response to the damage and also vary in response to whatever therapy you give them. The rate at which they sort of recover from it is also very key to what happens next. So if you have poorly controlled acute pain, you are really pushing the patient towards developing persistent pain. So needing to understand what the risk factors are for persistent pain developing. We call it persistent pain, by the way. It's a better term than chronic pain because it implies the chronicity where it doesn't have to be so. So take, for example, post-surgical pain. There's a wide variation, 10 to 50%, and you'll ask why. That doesn't sound clever, but it depends on what type of surgery you have, that the incidence of post-surgical pain will be greater. So, for example, post-mastectomy, post-phantom and post-leg amputation, hernia repairs, you'll be familiar with those patients who have had inguinal hernias repaired and had persistent pain. So hence, you can end up with 2 to 20% of the population. That is our number, 1 in 5 in New Zealand and all the other developed countries live with persistent pain. So it's quite an important part of us as a community providing support to our patients. So chronic pain is pain that persists beyond the healing time, or recurs or is present for more than 3 months. And that's our sort of broader definition of chronic pain. The World Health Organization has, as of last year, produced a classification of pain, chronic pain, with the ICD-11. So they've produced the first part of it, which is chronic primary pain, where pain itself is a disease. So it just because you don't find an underlying pathology does not mean the patient should not have pain. So the pain itself is the disease. So an example of that would be chronic widespread pain, otherwise known as fibromyalgia. For a long time, people thought it was in the patient's head. But that is a process itself, and it is a disease because it is pain. Patients experience a lot of pain. So those are some of the other examples of primary pain. So just put this in here, dysfunctional pain or nociplastic pain. So this helps you understand that pain is produced in the brain. And when you find that there's no underlying pathology or the healing process has taken place, but the patient still has pain, it's got to do with the processes in the brain. The brain has about 100 million neurons and some quadrillion bits of connections being made. And patients have abnormal processing, but no abnormality in the nervous system itself. It's about the processing that occurs at that level. So the term nociplastic, that's why we get excited in the pain world, is that you can retrain the brain to become normal again. That's why we say persistent pain and not chronic, because we know we can get patients to retrain to be able to have those normal connections as best as possible. Okay. So the second category was chronic secondary pain. So that stands to reason. It's due to some underlying pathology like cancer or post-surgery or trauma, neuropathic pain, be it peripheral diabetic neuropathy or central stroke pain, patients who've had a stroke, or multiple sclerosis, and a variety of other pain presentations. So in acute pain treatment, it's still mostly focused in the biomedical part of it. So providing a surgical procedure and intervention, providing medication, including analgesia. We still pretty much the biomedical aspect. But what we've all learned is that it's not just about the pathology. So we also try and get the patients, after they do their passive activities like rest and heat and ice packs and using walking aids and splints, you do want the patient to progress to as normal as possible. So activity is encouraged. Musculoskeletal pain is a huge problem in our community, and patients are on doses and multitudes of drugs just for musculoskeletal pain, which we can avoid. We can avoid the harm from the drugs, and we can avoid disability. So it's really important to identify it early in the pathway. Mind, body, and connection. So this is understanding where the patient is coming from, their beliefs, their understanding. Some of our clinicians, we have problems explaining to patients and reassuring patients that actually you feel pain, but we've done the investigations and they are reassuring that there's no abnormality, but that doesn't invalidate the patient's pain. And being able to give that message in a way that doesn't cause the patient more distress is very important. So we have to understand where they are coming from, what their experiences are at home, what their journey has been up to that point, and to be able to prevent them from having persistent pain. Nutrition and sleep are huge in our team. We look at that even on our acute pain rounds. We explain to patient why it's important, and sleep is quite an important aspect of their recovery, whether it's acute or persistent pain. So I've put this all on one slide just to save time, because time was short. But when we treat persistent or chronic pain, the biomedical side of it is a very small part of it. We focus a lot on the other aspects of it because it's the whole person view. Medication management, we rationalize medication, we wean and cease medication that has been tried and it's not working. There is no reason for patients to be on medications, it's not working. So weaning is very much part, and de-prescribing unhelpful drugs is very much part of what we do. In terms of activity, we want to prevent, or we want to reduce disability. There's a multitude of patients out there seeking wheelchairs and special beds and special lazy boys to be able to assist their mobility scooters, where they actually need guidance as to how to get back to that independence, that ability to move without having to worry. So the barriers there are fear and anxiety. It's really bad. So and that's what contributes to the disability. And it's in a lot of cases not necessary for patients to get that far in the process. In terms of connection, mind, body, what types of coping strategies they have, if they have any. Have they lost their ability to problem solve, their ability to cope by themselves, their ability to, they've lost family, they've lost partners, they've lost their connection with their people, their places, their culture, and we try to help them to connect again. It doesn't happen overnight. You have to sort of persist with your messaging system, and that's where as a team we could make it better. Dana will explain a little bit more on how to go about that process. Nutrition and sleep are very important. We know that obesity is a problem. It's very much related, connected with pain as well. Medication and nutrition, very important. So how we absorb our nutrition and how much drug we have that affects our gut biome to absorb our nutrition is a huge problem. It affects our immune system. A very low-grade neuroinflammation at the central nervous system is one of the outcomes of having a poor gut biome, because we got a lot of medication on board. So there's a connection between your gut and your brain, and that's a talk on its own. So yeah, sleep. I mean, we all know when we go to sleep, our bodies are actually going into a repair process. Our immunity, our mood, our appetites, all of that stress response and hypervigilance, it's all affected by our quality of sleep. And if that's not improved, it impacts on the pain experience directly. Sleeping tablets and benzodiazepines, they help for maybe a week or two, but they actually impact on the quality of sleep. So your sleep architecture is disrupted. So that's how it impacts your pain. So they're fatigued, they have mood disorders. There's a great overlap between psychological vulnerability and pain. It's whichever comes first, Dana will expand on that as well. So I think it encompasses who we are as a people, as a community, where we can take into consideration a person's journey, not just their pain and their cause of pain. It's how they've come to that point and how we can help them along to cope with it. Thank you very much.
Hello, everybody. So I'll just start off with, so ko tangihua te maunga, ko whangaumu te moana, ko tarara te iwi, ko Antonovich tuku whānau, and ko Dana tuku ingoa. So kia ora koutou, everybody. My name is Dana Antonovich, and I grew up here in Whangarei, in Maunga Karamea to be exact. I went on to Whangarei Girls High School, and I've now spent the last 7 years at university. Woohoo! And I'm now here for my last year of my degree, where I'm hoping to move the intern away from my name and become a health psychologist next year. So today I'm going to be speaking with you about some of the work that I do and how it's crucial to consider a number of factors in the pain experience and ways of doing that. Yeah. So because, as Chantal said, 1 in 5 people in New Zealand live with chronic pain, I'm sure that a lot of you have seen a lot of persistent pain patients. And as the literature continues to advance, we're starting to see how a number of different factors are involved in this experience. Therefore, these factors are crucial to take into account in treatment. So for the next 15 minutes, I'm going to be covering these 3 things here. So just a quick overview of some of the main psychological factors that are important in pain, and then how can we identify these for patients? And I'm going to show you a bit of a technique that can be helpful with that. And then lastly, just a little bit about treatment and what we can offer psychologically. So just a quick question, how many people living with persistent pain also have depression? Does anybody have any ideas? Any numbers, throw them at me. Yes. There is a lot of variance in research and the sort of overarching mean prevalence is around 52%. But as you can see in this study here, it actually ranges from 1 to 100 in different research studies. So yeah, so a lot of people. But does that mean that depression predicts pain? No. So yeah, so 65% of people living with depression will also report some type of chronic pain. So it's about, what comes first is a little bit of a chicken and egg thing, but there is more convincing evidence to suggest that pain leads to depression. But overall, what I'm trying to get at with this is that depression and pain are highly correlated. And, if you're not addressing both of them, then you're sort of doing a bit of a disservice in a way. So it's important to address both in treatment. The second concept that I want to address was this fear avoidance model. Has anybody seen this model before? Yeah, quite common. Yes, it's a really commonly known model of chronic pain. And it actually sort of beautifully summarizes of, how chronic pain can develop through a number of these interrelated factors and how it becomes a sort of vicious cycle when we don't address this early on in the set. Just quickly going through it, someone experiences this pain and then they have this quite catastrophic response to these symptoms. This increases this sort of perceived threat and this fear response, arousal, hypervigilance, and then leads to this sort of avoidance and escaping and results in this greater disuse, disability and depression, which then again goes into the pain experience. So based on this model, we need to be intervening at that early early level of that catastrophizing response. And this can actually be a really helpful model to show patients. I have shown quite a few patients this, and they start to see, you know, how it actually starts piecing together in the piece. But I'm just going to hone in a little bit on pain catastrophizing because you'll probably see this quite a lot in clinic. So it's a tendency to sort of fixate on pain, magnify its threat, and adopt a helpless outlook. You may hear people saying things like, I can't stop thinking about how much it hurts, or I'm afraid that, you know, something serious might happen, or there's nothing that I can do. You know, those are all sort of commonly reported things, well, in my clinic anyways. And it's really important because it's associated with a lot of negative outcomes, such as like the fear avoidance model just showed us, but also lower pain tolerance, higher pain scores, greater future disability, and future chronic pain. Now we're just whirlwinding over all of these other factors that are really important. You know, there's this sort of expected pain, hypervigilance and attention, sleep, as Chantal's already mentioned. Yeah, so there's a lot of factors to consider. And if anybody wants any more information about any of these, please email me and I'm happy to give out resources. It's just because of time restraints, I've not got enough to cover all of these. But what I wanted to sort of give, the message that I wanted to give you was that there are a lot of psychological factors that are important in pain. And so it's really important to ask about these and know a bit about them as well. But also it's really important to think about how can we talk to patients in a way that this isn't going to make them think that this is all in my head, you know, they're making me think that this is all made up in my head. If I'm going to see a psychologist, that is. So this is a way that we can sort of introduce persistent pain to somebody. It's created from Michael Nicholas in Australia and shows how we can sort of mind map different factors of pain for people. I've done it and recorded myself doing it and put it on YouTube so we can have a quick look at this now. I'm going to stop this share and then start sharing this one. Right, and we're not going to watch the whole thing because you know how awful it is listening to your own, not that one, listening to your own voice. Right, so we're going to start sharing this. Right.
Okay, so I'm going to be presenting the case of Josephine to you. Just
how do I change the? That might not work, will it? If I can't get the video, the audio. Can you guys hear it? Yeah. Okay, cool, great. I do talk quite loud, so it's probably quite a good thing in this instance.
Show you how to use this shared formulation. Now, the idea about this shared formulation is that it is as adaptable and sort of individual that you want to make it. So depending on what's presenting for that person, you can sort of chop and change what's sort of shown in their mind map. But generally speaking, the majority of persistent pain patients that I've seen, you know, all of these factors that I'm just going to cover now are important. Now, so what we like to do is, you know, as we do this, as we're talking to the patient. So Josephine is a 43-year-old and she's had lower back pain for 3 years. So the lower back pain actually started from an injury, so we can add that in. So it was an injury in 2017 where she fell on her back. And when she's talking about that injury, you might like to talk to her about what nociception is and how that plays a part in acute pain and how it changes to sort of more of the sensitization process in chronic pain. And then we're looking also about introducing some of the changes in the central nervous system, such as that sensitization process, you know, along the 3-year journey. And so we're introducing these ideas to her and helping her to understand this in a way that's meaningful for her. So you then ask, you know, Josephine, so how has living with pain these 3 years impacted you? So she starts by telling you, actually, it's impacted me so much You know, my whole activity is down. I can't work anymore. My social life is like non-existent. I can't leave the house very often. You know, it takes me ages to get around. I can't go on my trips with my family anymore. And just generally, like, I can't do any of the hobbies that I used to enjoy. And she said, you know, this whole thing is just being so restrictive. So she just has this overarching reduced activity. So then from this reduced activity, you then go on to say, you know, Josephine, if I had that reduced activity, you know, I'd be feeling pretty low, you know, how are you feeling? And she sort of says to you, you know, actually my mood is pretty bad at the moment, you know, I am feeling really low, and down. Most of all, I'm just feeling really helpless, you know, I'm just trying my best, you know, to try and keeping on going for my kids' sake and just to try and fight the pain, but nothing seems to be working. And then, you know, she says, actually, to be honest with you, I'm just getting really over it. And I just want to fix. I just want to cure. You know, it's just getting to the point now where I'm just feeling really over it, and I don't know what else to do. And to be honest with you, I'm getting really pissed off. I'm getting really frustrated. You know, so Josephine's told you about how pain has impacted her mood. You know, so then that's a segue here to be like, hey, actually, what we know about pain is that it has a very strong relationship to mood in the sense of, you know, biologically it does, and actually, you know, how it's processed in the brain. So we can say to her, hey, look, we know it's got a really strong relationship with pain, and so this whole feeling down and helpless and frustrated, you know, it's going to really be impacting your pain. So, you know, that's got a strong relationship. And then we have a look here, and, you know, feeling helpless, over and frustrated.
Yeah, it's one thing listening to your voice, but it's another thing listening to your voice in front of this many people. Cool, so I'll just stop sharing that one. So that's on YouTube if you want to watch the whole thing, but I'll just share the screen again. So from this slide, oops. Cool, so that's basically what it probably will end up looking like. Generally speaking, people will talk about pain first. They'll naturally go on to how much stuff they can't do anymore. You'll then probably hop on to direct them to mood. Often they'll talk about their failed treatments, and then generally speaking, it'll end up talking about the sort of overarching disability, distress, and sort of decreased quality of life that people will have. So, and although that's quite a rush job of what this is, it's sort of showing how we can start building a picture for somebody, you know, and start to think about how all of these factors that need to be addressed, you know, and helping them to understand that as well. Cool. So just briefly about some of the treatments that I use anyway. So I use two main ones, CBT and ACT. And it's useful to have a little bit of an understanding about what each of those are, because if you're trying to sell them to somebody to go in and see somebody about it, then, you know, it's helpful for them to know what might be in store. So if you want more information about these, please email me. I'm happy to send you some resources to send them as well. But basically, the aim of CBT is sort of to do this overarching skill-based learning, so giving them more skills to use, improving their physical and emotional well-being, and their reliance on pain medication. And those are the general things that we cover in CBT. And then versus with ACT, it's sort of more about switching the person's focus of how they relate to pain, and actually building up things and valuable experiences in their life on a day-to-day basis to focus their attention more in. So it's changing that relationship to pain and doing what somebody wants to do despite pain. And then it's got those 6 things that we cover there as well. Very brief, but that's generally what that is. So I really wanted to reiterate the importance of pain education at a primary care level. You know, from my research and what I've seen in my clinic, this is one of the most important factors for somebody to really understand what's happening inside their body. And I think it would be really cool to really drill this into them from a primary care level up into this tertiary level. And it's critical for a huge number of reasons, but really supports patients to start to adopt this self-management approach to pain quite early on. These are some helpful books that you can read yourself or give to patients, really well wrote. And these are my favourite websites to send to people and are really helpful for us as well. I play some of the clips to people in clinic with me, just because sometimes, you know, when you're trying to describe a process, it can be quite tricky. And if you're not really, if you've had this as the fourth person you've seen today with this, it can be a bit tongue-tie-y. So those are really helpful resources that you can watch alongside patients as well. Yeah. And yeah, so we're not doing questions now, but that's me.
Thank you, everybody. Our next speaker is Dr. Alistair Dunn, and he's talking about opioid dependence. Thank you.
Kia ora tātou, fantastic turnout, and thanks to the organisers. It's just brilliant to see the crowd here, although I suppose it also speaks to the great need that's currently unaddressed and we're all here to try and address. But I think it's fantastic that this new MAP scheme is getting set up, and it's nice to lay out what else is available. So who else should be able to fit something into 15 minutes than a GP? This was a 60-minute talk. It's going to feel like speed dating for me, and I'm sorry if it's going to rush, but put on your seatbelts and here we go. So this is the bottom line: prescribed opioid addiction. These are prescribed opioids. They're classified according to classes, Class B drugs, Class C drugs, depending on how strong they are. Can the sharp-eyed amongst us tell us what's missing in that list? Tramadol, absolutely. Is it a controlled drug? Not yet. They've had the meeting, they've said, yes, it'll be a controlled drug. So the ministry are changing it now to be a controlled drug. This will take approximately 2 years. Zopiclone, similarly, is on the way. Also, just to let you know, and thanks to Shane for reminding me about this, as of the 5th of November, which is not far away, codeine will not be available over the counter. So we may see a tsunami of patients rushing to the GP saying, I need a damn script. They'll be trying to manage my health, phone scripts. Get them in, do a review, find out what it's about, and you might flush out a few opiate-dependent people you can send my way. So controlled drugs. Why do we talk about controlled drugs? Well, it's to do with the law. This one, called the Misuse of Drugs Act, which says a health practitioner, not just a doctor, maybe a nurse practitioner, commits an offence if, when treating a person for drug dependency, they prescribe a controlled drug for that person, unless that doctor or practitioner is working for the Alcohol and Drug Service or is authorised by the service to do this. like we authorise doctors to prescribe methadone for people on OST. So you could have a GP prescribing 50 milligrams of morphine twice a day for pain, that's fine. But if you have a GP prescribing 50 milligrams of morphine to treat an opiate addiction, that's not okay. You should not be doing that. You should be, you need the blessing of an A&D service to do that. And I don't think you'll get it. So then there's this other idea about dependency, iatrogenic dependence. This is a term that's been around for a while. And this is harm caused by the interventions of the medical profession. And so hence we get people prescribed opiates who develop opiate dependence as a result of that prescribing. Dependence is defined best by DSM, DSM-4, DSM-5, changed the terminology. Substance dependence has now become substance use disorder. This is why white middle class Americans and DSM create these terms. But I mean, the bottom line is we're talking about addiction. That's what we're talking about. But then there's another term, physiological dependence. And this is really looking at tolerance and withdrawals without perhaps the other features of addiction that are the hallmarks of addiction, like loss of control over the use, the increasing importance of the substance use in their lives to the detriment of other domains, ongoing use despite persistent harm. That's more of the flavour of addiction. It's an impact on someone's life and their family. Whereas this, I think, is more neuroadaptation. If you give someone morphine long enough, this kind of stuff can happen. You don't need tolerance and withdrawals to define addiction necessarily. And if you've got tolerance and withdrawals but nothing else, you don't necessarily have addiction. So in general practice, what does addiction to prescribed opioids maybe look like? And you will recognise most of these. They're picking up scripts early. They go missing. The dog ate the script. You might find, thanks to the wonders of Test Safe, they've been getting another script of Valium or whatever from a chemist in Wellsford. Escalating doses, polysubstance and illicit substance use, a lot of alcohol use, overdoses, injecting sequelae, and amongst all this mountain of drugs, ongoing pain, doctor. It's killing me. I need my benefit extended. Not interested in alternatives, DNAing their appointments with other people. So I think it's important, if you see this happening, trust your gut. You're probably right. Discuss your concerns with the patient and seek their perspective about things. This is to harness your motivational interviewing skills, of course, with your open-ended questions, and then seek a response. And say, you know, look, I'm worried about your use of the opioid medication we've got here. I think you may have become dependent on it. And if you have, actually, I can't legally keep prescribing. Now, don't worry, I'll keep prescribing right now, but I really need to get a specialist second opinion about all this. So this is going to go down like a cup of cold sick. No way. I'm not going to drug clinic. Are you calling me an addict? How dare you? I've obtained these medications legally and I've been paying you for 10 years and now you're telling me I'm an addict. So fun with that one. Well, hey, I can't make you go. No, it's over to you. That's nice motivational interview. It's over to you. You don't have to go. But I don't have to keep prescribing this. I may be breaking the law if I do. And actually, opioids aren't the best treatment for chronic pain anyway. There are probably better things we can do. So, on the one hand, I'll keep prescribing while we get the second opinion. Let's just see what they've got to say. Or, I don't think I can continue like this, and I'm going to have to do a gradual taper. So this is about, I mean, opiates and opioid dependence, it's all about pain, isn't it? That's what we prescribe them for. So what about opiates for pain? Well, if I get my fractured tibia fib, damn right, I want an ED and I want lots of it. But long term, and this is from 2009, when we were preparing for the tsunami of oxycodone, it's a while ago now, but there just isn't good evidence for long-term use of pain. I know there's been a lot of media about the lack of evidence for cannabis for chronic pain. Well, hey, it's no worse than the evidence for opiates, and there's a hell of a lot less harm when you compare what we see, or at least what I see in my work, with opioid addictions. So, chronic pain, opioids, well, what about non-opioid medication? And then, as you've heard wonderfully tonight, there's a whole multidisciplinary team of other stuff out there. And what are the risks? Well, we know it's tolerance, but it's worse than that. You get hyperalgesia. So I see patients on 100 milligrams of methadone a day on the program, if they stub their toe on the door, it's going to hurt them a hell of a lot more than it hurts me. So they're going to get less pain if they reduce their opiates. Addiction, overdoses, and crucially, no improvement in function. They end up with the same back pain, but the opiate habit as well. So this is the bottom line. This is what my topic's called. Opiates are a dumb choice to treat chronic pain. And I want you all please to say out loud again, opiates are a dumb choice to treat chronic pain. We could just end it there. But no, some of you are still prescribing. Of course, we all inherited these guys. I know we did, you know, I mean, you've got to carry on. So here's a few red flags to look out for. Number one, past history of A&D. It's a huge warning sign, right? If they've had addiction problems, doesn't matter what the substance is, it's the same dopaminergic pathway that's primed and ready to go bing when you add an opiate. Family history is equally important. It's a huge genetic load to addiction. Aberrant behaviour is a quaint term from the literature. You know, this is the guy banging his desk at 5 o'clock in the surgery, making your receptionists feel horrible. And also Hep C is a bit of a red flag because, you know, in my experience, it's pretty, you know, not most of the time it's related to some injecting somewhere. But it's not just the tattooed ruffian coming into the surgery at 5 o'clock. Sometimes your patients can have no history of addiction, no history of illicit use, always obtain their medications properly and appropriately through their doc, and they come unstuck. So here's some quick prescribing tips for the prescribers amongst you. Dispensing. I hate this 10-day dispensing. It must be a nightmare for the chemists. You know, it's like when your kids at primary school and they have a 6-day timetable, and swimming changes every week. If they're picking up their opiates every Wednesday, you know, hell, it's coming to you. You're early, mate. What's going on? So you can pick up people running out early. Have a review date. If you are starting, you know, you start an antidepressant, you have a review. Have a review of this. Is it working, as you're saying earlier? You know, if it's not working, why are you still on it? Dose limit. Now, this has changed over the years, what you asked, what the answer is, but if you're a doc and you're prescribing morphine, 24-hour dose total, you start and you titrate up like you do an SSRI or whatever, but you have a limit. You don't keep going with your SSRI. You say, that's enough, I'm going to change tack. So what's an upper limit? Yeah. 10? Oh, I'm going to be a bit more generous, mate.
2 grams.
Go on, I think what I mean, anyway, 60, 100, what, 30? Are there any docs here? Okay, so, you know, 5 years ago, 10 years ago, GPs would say 100 milligrams, 50 twice a day. Now, new generation of registrars are saying 60. So, you know, it's coming down, which is cool. I'd take 60, what the hell. So, outcome measures, functional goals. I don't use this on a scale of 1 out of 10. Just get some thinking about their pain all day long. I mean, I try and personalise it, their goals, like, you know, what do you want to do, what can't you do at the moment, what would you like to do? I want to get to the letterbox to get the newspaper, I want to get to the beach, I want to take my son to football. So, okay, that's your goal, and have a review. Did you get to watch half a game at least? You know, how did it go? And those are the goals you're going to measure whether this stuff's helping or not. Contracts, or call it consent, that sounds a bit more PC. These are quite useful. You can Google them, especially to do with opiates. It highlights the dangers of opiates, why there's weekly dispensing, what the harms are, that they can get stolen, that people might use standover tactics, that you can overdose from them. They read all that and make you sign it. Hell, this is serious stuff. Urine testing is a bit of a difficult one in general practice. I mean, I get urines done at work all day long on my clients, and you know, it's easy there. That's the kind of paradigm we're in. But I don't do it that often in general practice. But the 2 times I have, I found methamphetamine. So again, trust your gut. And a restriction notice is a quaint thing we've used over the years. In the old days, you had to get this bit of paper and fax it down. Now they've gone online, but it will restrict supply of a controlled drug to 1 doctor, 1 pharmacy, and it's really good for stopping doctor shopping. So those are your prescribing tips. So can someone tell me a red flag? History of alcohol and drug problems, yes. And another one? Family history. And the third one? Cool. And remember, repeat after me, opiates are joys to treat chronic pain. Some resources, Health Navigator. I have to admit, it was a practice nurse at work that told me about Health Navigator. I've been ignoring it for years. I had a look, actually it's really good. So thank you, Rob and Ann. Now, if you enter opioid or opiate meds, you get some a great little video clip. I don't know if you guys have seen this one by American or guy, but Dr. Mike. Really nice advice using that cartoony stuff, and it simplifies all my worries about opiates, but it puts it in a cool way, way more eloquently than I can. And if you put in chronic pain, you get some of that nice pain theory stuff as well. Also, for those GPs that have to do that pain in the ass annual MOPS audit thing, I made one on controlled drugs. You can get it through the college. It does a query builder of all the opiates you're prescribing long term, and you can get like a little template to make sure you've got a classification medtic explaining why the hell you're prescribing it. Make sure you've had a review pain team or psychologist or whatever. And BPAC's got some stuff as well. That's it. Thank you.
Thank you, everyone. Our next speaker is Dr. Grant Thompson, and he's the musculoskeletal physician, and he's going to provide an overview of his service. Thank you.
Thank you, Wendy. Well, there's myself and John Malloy, so I've got John works part-time with me now, so that's been a great help in the last couple of years. Kia ora katoa. This is Goat Island Numaru, and it's just to remind us in the turmoil of the world at the moment how lucky we are to be these small islands in the South Pacific. Now, I could just leave that, and that's really the summary of my talk. So, really important to appreciate the difference between nociception and pain. So, nociception is a sort of an on-off switch. There's tissue trauma or tissue inflammation or torsion, and pain is what we express, and they're not the same. So we get there's a peripheral sensitization, central sensitization, and those are normal processes physiologically, and then sometimes we get pathological sensitization. And we've already gone over, this is the previous IASP definition for pain and sensory and emotional. And even the new definition, it still talks about the sensory and emotional experience. And the IASP described 4 different types of treatment providers. So there's unimodal, for example, you go to an acupuncturist. There's multimodal, where the one therapist or group of individuals might offer a variety of treatments. Multidisciplinary is where you might get a medical, a functional and a psychological input, and those practitioners are working individually and then combine their report to come up with a treatment plan. And interdisciplinary is where they actually may consult together and certainly meet together, and it's probably the ultimate, because the professional boundaries disappear after a period. And that's so multidisciplinary is what we're really doing with the ACC Pain Management Service now. And the interdisciplinary would be the hospital pain clinic and TARPs. And we also used to do that with the comprehensive pain assessments. Now, I'm going to let you into a secret, but the pain clinics, they don't actually treat pain. So they might be in the acute, but when you've got someone turning up after a year or two, they're treating not pain, but pain-related disability. And so they're not looking for an answer to pain, they're looking to try and help that person manage their distress. So this guy here is obviously suffering. If we look at Luce's onion skin model, there's nociception and then pain and then suffering. And you could look at that and he's distressed and suffering. And you can think, well, he may have intense pain. He may be worrying about something else in the family. He may be a GP contemplating the morning's list. So you can't really tell, but he's obviously suffering. This is a pain map, and I can't advise you strongly enough. This is a 20-year-old referred to me for low back pain. And you look at that, and that just smacks of someone that's highly distressed. Now, I don't know any medical treatment, oral or injection, that's going to help that pain, sadly. And it actually is quite hard to get appropriate treatment for someone like that in our community, through public or private, very hard. This is this paper is a pooled assessment or meta-analysis of for people suffering low back pain. And if you look the odds ratio up the top there, female gender 1.67, so that's really nothing much. Previous history of back pain 1.45. Pain intensity only 1.92 for somebody presenting to a practitioner, to a professional. That's still pretty low. But then we get down to high levels of disability, and that's 7.66. So people aren't coming to you because of pain, they're coming to you because of their perceived levels of disability. There was a study in Australia that showed that people with chronic low back pain, only 1 in 18 presented to a health professional in a 6-month period. And you say, well, why that 1 in 18, why not the other 17? Or why do 3% of people with headaches present to a medical practitioner, not the others? So it's all about perceived disability. And it's the psychological factors, anxiety, depression, fear avoidance, that they are not causative for pain, but they are perpetuating factors, and probably about 3-fold more important than the medical factors involved with that person's pain or nociception. This will be all probably familiar to you all, but so we look at the different groups of pain. There's a nociceptive, which is somatic, tissue distortion, and that's that will cause that rather deep, vague distribution of pain. There's neurogenic, so central neuropathic, which would be like post-stroke thalamic syndrome, or peripheral with the neuralgias, post-herpetic neuralgias. Radicular pain is a specific subtype. Complex regional pain syndrome, where you get peripheral and central inflammation in the nervous system. And then we talked, it's already mentioned tonight, about nociplastic and central neural sensitization. So a certain amount is normal adaptive, and then you get the pathological maladaptive nociplastic pain. And then psychogenic are the somatization disorders, conversion disorders, which are not that common. But more often, most of the psychological distress we see are secondary to nociceptive pain. This, in this picture, only one of the 3 is radicular pain, and the other 2 are somatic. So somatic is, and most pain you see in the periphery in the limbs will be somatic referred. So somatic referred is typically rather ill-defined, deep, aching, throbbing, maybe like broken glass, whereas radicular nerve root is very, it's so in a very narrow band, it's quite superficial, The books say lancinating. People don't come and say, I've got lancinating pain. They say it feels like a red hot rod being reamed up and down inside my skin. So it's a very superficial one. So the one on the left is radicular pain. The one in the middle is myofascial pain from the gluteus minimus. And the one on the right was published by a guy called Calgren in 1938-39, and he injected hypertonic saline into spinous ligaments and muscles and plotted out the pain distribution. And that, for all the world, looks like an L5 radicular pain, but that's somatic referred pain. So radicular pain is easy because it's well defined. We might examine and find signs of radiculopathy, and then we go and do an MRI scan and find there's a nerve root being pinched, and it's quite easy to treat. Well, you might start off with oral medication, go on to something like a transforaminal or epidural, and it's got a good outcome. Somatic pain is more difficult because most of the structures will cause overlapping pain referral patterns, and it's not diagnosable usually by imaging. If we look at neck pain, there's a lot of potential sources of pain there. Statistically, the zygapophyseal joints would be most common, and particularly after whiplash type events. With persistent headache, it would be C2-3. In this study, 53% of the time. And that's because of the trigeminocervical nucleus, we get that referral pattern where we get suboccipital, occipital pain, and then retroorbital pain is very common because particularly the ophthalmic nucleus is opposite C2-3. So it's due to neuroconvergence. And then below the lower neck, zygapophyseal joints are probably responsible for about 50% of persistent neck pain. And in the neck, we get these very classic referral patterns, and it doesn't matter whether the pain is originating in the zygapophyseal joint, internal disc, or ligaments or muscles. The referral pattern is very consistent for the level of referral. In other words, if it's C2-3, it'll be suboccipital, it'll be occipital. If it's 5-6, it'll be suprascapular, it'll be into the chest, and so on. And but the referral pattern doesn't tell us what structure is actually causative. And we've already, you're probably familiar with, this is a rather artificial constraint, talking about acute being less than 8 weeks, chronic being more than 3 months, and then a common pattern is acute on chronic. Because if we look at something simple like uncomplicated low back pain, the median time to recover is 7 weeks. So that already puts us into the subacute, and that's normal. And the other thing was just normal uncomplicated low back pain. At 1 year, 80% of people are still disabled, 10 to 15% highly disabled. So it's not as benign as we often make out. We have provocative tests and relieving tests. So if we wanted to check something like the zygapophyseal joints, traditionally we'll do intra-articular injections onto imaging, or more specifically, we might do medial branch blocks. And in the medial branch block, what we're doing is we're using local anaesthetic in the neck. It's at each point it'll be 0.3 mils the local, and the low back 0.5 mils. We'll be using comparative local anaesthetic, say lignocaine, which should work no more than 2 hours, or marcaine, which will work more than 2 hours. We keep the patient and the assessor blinded to what we're using, and we'll use it, do at least 2 blocks on different occasions, and we're looking for a concordant result, so that somebody who gets 100% or nearly, or at least 90% of pain relief from that minute amount of local, and it should be under 2 hours if it's xylocaine and more than 2 hours if it's marcaine. The main, as far as referrals go, we had during the lockdown, we caught up our waiting list fantastically. It was the best it's been in 15 years. And it got even lower, you know, it was shorter than the average general practice waiting list. It's sort of expanded a bit now, but the sort of people I want to see quite early on are people with radicular pain, particularly sciaticas, because it's such a miserable condition, and what I suggest is hit hard early with oral medication, and if you don't get results within a few days, then the epidurals are so effective for them. And the other one are the CRIPS, complex regional pain syndrome. At 1 year, only 5% of people are asymptomatic at 1 year. So unless you get in on early interventions, and they're sort of lost. So at 1 year, depending on whether you use the Orlando or the Budapest criteria, sort of 30 to 40% still have CRIPS. The others all have neuropathic pain. And just to finish up, so that's a leopard anemone, and it's photographed by Richie Robertson out at the Poor Knights. Thank you. I'd like to ask the first question. You know what I'm going to ask? No. We have to talk about tramadol. Do we? Yes. Now, it's an atypical opioid. It appears to me it's quite a low rate of tolerance and dependence. Now, in the last 50 years, we've probably had about 50 new analgesics. A third of them are triptans, a third of anti-inflammatories, and there's very few others. So if you're in general practice, you've got very few choices for analgesia. And so I just wonder if you could share, I mean, how often are you treating people with tramadol dependence and compared with the other things?
Yeah, so yes, we do see tramadol abuse, and we see patients with tramadol dependence. So I think all opiates, that's my message, any opiate has this potential, and so people can come unstuck with any opiate, which tramadol is no different to the others. That people like that. And we've found that actually prescription opioid dependence, especially people who haven't had a history of other substance use or injecting, Suboxone or buprenorphine is a really cool option to treat prescription opioid dependence. Buprenorphine is a milder OSD substitute opiate compared to better and found very effective. Back to the audience. Who's comparing this? Are you taking the question?
Have you got the microphone to us? Is there any questions?
Roll up, roll up.
I just want to clarify, a question from Alistair about the, sorry, it's just a general question. So if we start somebody on an opiate and they then become dependent and we then keep prescribing it, are we committing a crime?
Well, you can still say you're treating pain. So there's always that kind of loophole. But I think once you become aware or you think there's a dependence problem that's there, I think it's prudent to get an opinion. And I've been referred patients with a chronic headache and they've used an opiate for it, and I've assessed them and they don't have addiction as such. The dose is maintained, it's not escalating, there's no sort of dysfunction going on in their life, it's actually enabling them to work. They have a family, they seem to be, they don't have any of the other sort of comorbidities you might associate with addiction or the harms associated from it. I've written back to the GP saying, for this patient is working, carry on. And you've got to have these things, so that covers their medical legally.
Questions of them.
No, we've got to have a question from someone else. Well, I should just read the question out. The role of naltrexone in chronic pain treatment.
Well, we're probably talking about the low dose naltrexone. Just like most things out there, sort of falling in the cannabis category as well as the low dose naltrexone. There are very small studies out there with a multitude of conditions, everything you can think of that produces persistent pain. In terms of sort of quality studies and evidence-based, where we look for large numbers of patients and for over long term, there are no studies that actually convincingly say that it helps. Personally, I know of only 2 patients who have gone on it, and that's about it. That's my total experience. It's available, you don't have to pay for it. There's a compounding pharmacist in Auckland that does it, but it's being used for every type of condition. The mechanism behind it is that the low-grade neuroinflammation that I talked about happens with the glial cells get activated in the brain. On them, they have a toll-like receptor, which the naltrexone, low-dose naltrexone works on to be able to reduce. That's the basis for the use of the drug, is reducing the neuroinflammation that supposedly then reduces the central sensitization. So that's the neurobiology behind it. In terms of the sort of accumulated evidence in the literature, it's not sort of mainstream as yet. I mean, I'm sure there'll be more studies coming out, as more people use it and more studies sort of get on board, more institutions and sort of around the world. So when you have a consensus amongst the groups, you will hear more about it, but that's the basis for using more focus naltrexone.
I got away in much bigger doses. It's also used to treat alcohol patients, and there's a bit more evidence for it. Snag is it's an opiate antagonist, and the big doses, if you're taking any form of opiate and then you take a naltrexone, it's like Narcan, suddenly push all those receptors off and cause unpleasant. Cool.
Yeah, that's
Oh, I like this.
So this is, it was a day we had direct dial numbers to contact trusted ACC staff.
No.
Numbers don't work for ACC. Can we go back to the old days of ACC? Want to not sure how to answer. We do have a phone list for Whangārei sites still, so you can still ring staff at Whangārei ACC to ask for help. Which I think I've given to share out. All I would say is if you're really struggling and you've tried the methods that you should be using, and you can't then bring a team leader in front of a to start, it's fine, and we can kind of work through why it's not working, what the issue is and things like that. We're quite aware that there are delays and things at the moment with some of our new ways of working, and we do want to obviously maintain good relationships and things like that as well, so we can share that.
Are you a team leader?
I am team leader.
All right.
I don't really need one of those. No. What do you think of DEA, anti-neural type substance? It's pretty big in Australia.
PEA, an anti-inflammatory substance?
It's high-tech. Apparently stuff out of Hornsville and stuff out of Australia.
We're not likely to get it.
Oh my God. Polymethyl ethanolamide. Neuronal and non-neuronal cells. Apparently it's, I was told that it was pretty interesting.
I have colleagues using it in Aussie.
Yeah.
But like a lot of these things, there's no panacea.
No.
It's just like CBD is not going to be a panacea for all pain. So the question I've got is alternative options for ketamine infusions for exacerbations of crips. For acute crip, if you get it early, it's certainly worth trying prednisone, crash course for prednisone. There's not a lot of evidence for the medication like tricyclics and gabapentin and pregabalin that are often used. It makes good sense for early mobilisation, where possible with pain permits. And the other thing are bisphosphonate infusions that are used early in conjunction with mobilisation.
It depends on what you define as exacerbation of crip. So one of the main things we like to do is if we know somebody has had a history of crip and overcome it or is maintaining a good quality of life despite it. If there's a chance that they will be, say, coming for surgery or they've had an injury, that puts them at risk of having a flare of pain. It may not be a flare of crips as such, but it may be a flare of pain. Just remember the brain has these files with memories in them, and they kind of open these files and experience some sort of adversity. So it's also on a patient-to-patient basis. There isn't a one size fits all, but help first with the patient understanding that that is a risk, but it can be overcome. If they are showing signs, it would be important to send them to the physiotherapist to help them with mobilizing, but also desensitization. So they do things like nerve therapy. So should he train the brain to accept that that area of the body is now, it's okay, it's normal. So that's my contribution. So it just depends on what you face with, what the circumstances at that point. Are you dealing with a severe acute painful condition which is unrelated to previous problems as well? So it's desensitizing that. Plus understanding, accepting that that may be a problem. If you had somebody who's had trips before and is going forth for surgery or has a chance of developing a problem again, vitamin C is touted as one of the preventative agents for crips as well.
It's hard for primary prevention, but where it is for secondary prevention.
Well, we've used it just for the benefits. Yeah. So there's a lot of stuff there. There isn't a pain medication or medication that's going to treat all patients, and that's where we come unstuck. There's the biomedical approach. Everyone thinks there's a medication or a procedure, but there is no medication. It's not very sexy at the moment. Chronic pain is really not a pharmaceutical gene, a pharmaceutical company gene, because it's just not worth it. It's not worth the money, it's not worth the effort. So that is why we want for a long time have the development of the ideal drug. But time will come because people are working from the genetic point of view where we'll be able to genetically identify those people who are more vulnerable, predisposed to painful condition, and then tailor your medication to that person or to that type of medication. So,
my question for Wendy. Who will see those patients under the NAP program? Is it just specific private practices, or where are they going?
So yeah, there'll be a range. I'll be literally trying to get all the private practitioners on board, both physio, podiatry, pharmacy, nutrition. So it's having patients will have a range of different providers that they can choose from. So you're broad. And that's going to be starting tonight, is just getting the interest. So that we can have a database and yeah, we can get through. The other question that I had was, if the program is successful, will it be ongoing? Because we had pilot before. The really exciting thing is that it's now supported by the Ministry of Health, so it is actually there's ring-fence funding. It's still, in my opinion, vastly less than what I think the actual need is, but that's where I'm hoping, very lucky with MSD, so that combination of Ministry of Health funding and MSD together, I think, and linking with already established service in the community, we'll get a really useful service. So, yeah.
Just got a question for you. Just wondering how patients would access those services, or would you get in touch with the providers or the pharmacies regarding those patients or physios, or would you leave it up to the patients? Because a lot of the time the patients would, they just have a blank, they wouldn't really know what to do there. So how would you contact us really about that?
So it would be coordinated through here, through the actually. So that's initially my role, but that will roll out a bigger administration team as well. So basically, we'll coordinate that, where we'll contact the providers, and then they will then ring the patient to make an appointment.
Just going to clips a little bit, just as a personal experience, but is there a definitive way to diagnose clips, or does it present itself differently with different clients? Yeah.
So they have
it's a clinical diagnosis. The IASP has got criteria, and so we apply those. There's no diagnostic test. So Orlando was the original one, and then subsequent Budapest. And Budapest is probably more research, but then there's also a group that qualify under one group of criteria, not the other. But we actually go through and use those criteria.
Just, because in my instance, I had a client who, she's got post-radiation but anyway, she was diagnosed by a neurologist down in Auckland to have Crips. She wasn't a classic client I would have suspected to have Crips, but so she then got referred to TARPS in Auckland, and we sat down with a specialist from TARPS who just flat out refused that she had Crips. And we just walked away completely confused.
So the IASP criteria are critical. And part of both criteria is that any other condition which would explain that pain is excluded, so you've got a flexopathy, you're going to get neuropathic pain anyway.
So it's one of the criteria that it should not be explained by another pathology.
I've got a question. Wendy, you mentioned the $15 charge for like a non-WINS card holder. Is that for every session or for the whole lot?
No, it would be for each session. Again, we've got discretionary funding, so if we deem that that person is still struggling, then we would cover it. But I'm just aware that if, with the funding that we have, if we don't put things in place, it will be gone.
Yeah, no, I don't. And I think, what's the physio cost with ACC? Is it $20? 35. Roads and child, I mean, so 15 is still pretty good.
That's really good. Yeah. So it's just trying to spread it up there so that we can offer more, but if we can see that that's a real barrier, then
I think patients will be okay with it, because it's just the same as the other ACC.
that's the whole idea, they're very close. So
Maybe it'll make them drop their fees a bit.
That's what this is.
Just a question for Grant Thompson. What's your advice on scans? Because you talked about the prescription drugs and negative effects that can have, but also scans when they're overdone, the negative effects that can have, asymptomatic findings on people. What's your sort of clinical reasoning behind that?
That's all true. So, I mean, obviously it depends on the individual circumstance, and so if it's something like radicular pain, where we need to, if we're wanting a level, we might have to confirm our clinical findings, we might do that early on. But most of the negative pain, we're not looking at under 3 months, I'm sure.
Okay. Yeah, it's just because in my experience, a lot of people come to me and their scans aren't always, the picture we get from their scans isn't always relevant to seeing interview, and it can sometimes complicate things. So it doesn't work. In my experience, sometimes we own the scan to expect, like, trying to find serious pathology or rule it out. So,
you often pick up opportunistic things, and sometimes they might be quite important, and the scan of lumbar spine, find got CA kidney or something. Yes, those sort of things happen, and then other times we pick up findings that we're unclear on, which leads to a repeat scan in 6 months' time, or further investigations to clarify. So that's absolutely true. No debate with that.
Right, thank you. I know you want to try and get home, so thank you to the panel for. Oh, sorry.
I've got a question for Wendy. If the NAT program is targeted to Māori, is there provision for Māori health things such as roaming and?
yeah, definitely, that's what I was saying, sort of had discussion already around that, like those providers, that sort of list of NDT, we're definitely looking at potentially expanding it. So yeah, open to that, and also the whole model of the education, we're looking at developing it in a Māori way, and I'm getting assistance with that. So yeah, again, any input, help, opinions, totally open. So yeah, looking at we can collaboratively with that.
All right. Okay, thank you to the panel for coming, and thank you to you all for coming.
And thank you to those who are still on Zoom. I hope you've appreciated. For those slides that I got late, the presentations, you will get them sent out to you in the next few days. And I also will send a survey out via survey note if you will complete it, would be appreciated. Thank you. We're done.
This is